Welcome to the show.
Yeah, exactly. And that's a great way to get on this show, by the way, is just come up with a diagnosis en route and stop. Hey everyone, welcome to the second episode of welcome to the second episode of Push Dose. I forgot to hit the record button earlier, so that is why I am a little silly at the moment. But yeah, welcome to the second episode of Push Dose. These are miniature episodes that are very similar to episodes that you would find on our podcast, EMS 2020, where we review real out-of-hospital calls. Now, not every call we receive that got submitted to EMS 2020 is long enough or necessarily has the meat that would make a full EMS 2020 episode, but we can make a push dose episode on the Rapid Sequence Information channel, and so that is what we are doing. Today's episode is brought to you by Jump Medic. They make premium first aid kits. We'll be talking more about Jump Medic premium first aid kits in a little bit. As always, if you enjoy this video, please hit the like button, and as always, subscribe to our channel and click the bell icon so you don't miss the next videos. Those things really do help the channel out quite a bit. So without further ado, I want to bring you my co-host, Spencer Oliver.
Well, hello there.
Hello. Well, they're just going to have to look up my nose.
I didn't see you there.
Right? Spencer, today's call is going to have two of my favorite lessons. One of those lessons is to try and trust your patients. I know sometimes that's hard to do, but, I guess say, true until proven otherwise. And the other lesson is make sure you have all your kits with you. So, yeah, if you've listened to our podcast for any amount of time, you know that that is a pet peeve of mine. That being said, the circumstances in today's episode is quite a bit different than what we've been used to in the past. So, yeah, there's better reasoning behind it, and it's more of a system issue than an individual issue, but we'll get there. So today's episode takes place in a busy metropolitan area. The primary 911 service primarily responds to 911 calls with a fire response and then a fire transporting unit as well, depending on what's going on with the call. One situation where they won't do that, where they'll commonly just send just a transporting unit, is for standby events. Now, standby events are typically when you have a large event, and in this case, it's going to be the Furby Expo that may be made up entirely. It is.
Yeah, let's do Beanie Babies, because Furbies is...
That's a stretch. All right, Beanie Babies. Is there controversy about Furbies that I don't know, that I step on all the time?
No, I don't know. I remember Furbies, and I was like, ugh.
Yeah.
And they don't make enough of them to really have a convention, do they? I don't know anything about Furbies.
Well, considering the convention's almost entirely made up on the spot right now, and the call is a true story, and it did take place at a large event, but it was not a Furby or Beanie Baby convention. So we'll stick with Beanie Babies, because that has probably
unicorns.
All right. It's a unicorn convention. It is a unicorn convention.
We're going to Candy Mountain. Come with us, Charlie. Yeah, Charlie.
And so the unicorn convention is actually staffed by paramedics and EMTs. And that's pretty common in a lot of areas. In fact, you can almost guarantee if you go to any major sporting event or event period, there's going to be some level of EMT or paramedic staffed on site. Now, in some areas, you will actually have the 911 system itself will staff the event, but in a lot of areas, you may not. In a lot of areas, there are agencies that is all they do, and that is the case today. The local agency that provides these standbys oftentimes have employees that also work in the 911 system, and they work here to pick up extra overtime and that kind of stuff as well, but sometimes they don't. And that kind of gives the agency a hit or miss reputation because some of the paramedics maybe don't have a lot of transport experience or 911 experience, and so their experience and how they treat a patient doesn't necessarily translate very well to the 911 system, and they have to call the 911 system to actually transport somebody. The staffing at these events can treat on site. They have their own kits, but they do not transport. They rely on transportation from the local 911 system. If an event requires to have transport on scene at all times, available on scene at all times, then the 911 system will have to staff a unit there because this agency doesn't transport. So that said, I mentioned the kits earlier. One of the good things, though, is that the agency that does these standbys does have very good kit parity in terms of what they bring in supplies-wise with the local agency. And so oftentimes when responding to these events, the local agencies will not bring in their kits, or they may bring in maybe just their narcotics bag or their rapid sequence induction kit, something to that extent, but they don't really.
Gotcha. The standby kit is close enough to what they have.
Yes. And so if it's an ALS standby, which this event is an ALS standby, so there should be
Okay.
ALS equipment available on scene for anything serious. So our call today is brought to us by a paramedic who, at the time of this call, had just become a paramedic. I think they had gotten their certification for a whopping 5 weeks and has been working for like, I don't know, maybe 2 weeks on this ambulance with their current partner. So they are in their training phase. And let's give them a name with the patented EMS 2020 Namerator, also known as the Old McDonald wheel.
Old MacDonald had a farm, E-I-E-I-O.
Perfect.
On that farm he had a goat,
I guess it's Old McDonald
Well, hold on. Wouldn't it be Junior McDonald?
because they are the junior
Young
partner on the
McDonald?
rig. Young
Yeah,
McDonald.
yeah.
Let's call him Young McDonald. I like that.
Young McDonald.
So Young McDonald, one thing to note, Young McDonald has been an EMT prior to getting their paramedic for about 5 years in a more rural system. They recently moved to this urban system after they got their paramedic because the pay, it just made sense. So their partner is going to be...
Old MacDonald had a farm, E-I-E-I-O.
We can't do that twice.
No,
I guess we
it'd
could
be
do
Old
Young McDonald and Old
Yeah.
McDonald.
Old
Do you want it?
McDonald. Yeah, let's do it.
This won't get confusing. I
Yeah.
foresee no
Now,
issues.
Chris, hold on. Question for you.
Yeah,
They came to the city because the hay was better?
the pay was better, Spencer.
Oh,
Okay.
sorry. I missed that.
If you contribute, you know what, buddy? If you contribute one thing to this episode, that's it. That's it right there. You did great. Alrighty, so getting on with the call. Our plucky crew that gave us this call, they are just tootling about. They typically work 12-hour shifts. They are on the ambulance frequently. They technically do have stations that they return to, but it's rare they actually get back to them. So with that, they're about middle of the day. They're not really missing lunch. It's not the end of their shift, so yeah, it's been an average shift so far. When they get the following call, they have to respond to the arena, the Beanie Baby arena. And,
Unicorn.
The Unicorn Arena. They have to respond to the Unicorn Arena.
It's a land of sweets and joy and joyness.
And they're responding for a 19-year-old female with breathing difficulty. And one little extra nugget, they have taken some drugs.
The snozberries taste like snozberries.
So Spence, when you hear this read back, what do you think?
I mean, the first thing that comes to my head is some sort of anxiety with, drugs. But, you have to chase that with what could actually be wrong.
That's
You know,
very
it's
true.
fair to think, hey, all right, maybe it's anxiety, because a lot of times that's what it ends up being. But it's a mistake to just go, that's probably what it is, and stop.
Yeah.
So, like maybe there's asthma, maybe, there's some sort of allergic reaction that's taking place. There are very potential and real dangers with shortness of breath, even at the young age of 19. So,
Yeah, I mean, this definitely sounds like it does sound like a typical anxiety call. Given your reaction there, how do you think their pre-game went? Which, by the way, if you're not familiar with pre-gaming, we talk about this on our podcast, EMS 2020, quite a bit. Pre-gaming is basically where you talk about the call prior to arrival and try and get a few things sorted out. Because there's always that pre-arrival conversation. That's what we call the pre-game. It probably consisted of going down all the meaningful possibilities and making sure we take the patient seriously from the get-go.
Well, when you say it that way, it makes me think that they stopped at like anxiety or bullshit.
100%
and
they
just
did.
Went, yeah. Oh no.
That is precisely what happened. So yeah, they said,
Welcome to the show.
yeah, exactly. And that's a great way to get on this show, by the way, is just, come up with a diagnosis en route and stop. So that is true. So that's what ended up happening is they said, hey, it's probably an anxiety patient. Not only did they say it's probably an anxiety patient, they then also proceeded to kind of say like, yeah, I bet this isn't going to be anybody that we know on scene. I bet it's going to be some, wet behind the ears paramedic that hasn't worked a real call in 100 years or ever. And they just don't know what they're talking about. And they're having to like give us this anxiety patient. Yeah, that kind of stuff. And that is what their conversation ended up being. So they arrived to the Unicorn Arena. And which is, I guess, it's quite the rigmarole to get inside because you have to park around back, you have to follow a security guard up, you have to get a security pass, you got to get a radio.
You have to convince the elf that you're worthy to cross over the Rainbow Bridge to get to the land of unicorns. Yeah, no, it's
it's terrible.
Yeah.
Got to answer his riddles. It's ridiculous. So with that, They do finally arrive to where the patient is. The patient is in one of the med rooms on one of the floors of the arena, and they are greeted by 2 EMTs. Now, you may recall me earlier saying that this was an ALS staffed event. Well, all that really technically has to mean in this area is that there's at least one paramedic. Now, there is more than one paramedic at this arena, but it doesn't necessarily mean that the person you're going to talk to when you arrive is going to be a paramedic. In this case, they absolutely weren't. And the reason for that is that the EMTs didn't really feel that ALS was truly necessary. The way calls are dispatched in this area, and I should note that our crew did arrive licensed sirens, if I didn't say that earlier. But the way it's dispatched is even if the on-scene EMTs that are providing standby care call, they don't request a code status. They just say, hey, this is what's going on, and it's up to dispatch to triage and then send based on what their triage cards say. So in this case, they sent just a transporting unit, but they did send them lights and sirens. They arrive and they get in there, and EMT says, hey, we got our patient back there. She's just having a huge anxiety attack right now. All of her vital signs are fine. Her lung sounds are clear, but she's saying that she just can't breathe. At this point, our new paramedic, young McDonald, young McDonald is in the PIC position purely because he's in training, and this doesn't seem like it's going to be too complicated of a call, so he is going to go ahead and take the lead.
Young McD is PIC.
Young McD is PIC. So he gets this report from the EMT, and he's like, okay, like at least they're telling me it's anxiety, and they're like, oh, they're not working up. So the anxiety seed has been planted. They walk in there and they find a 19-year-old female who is sitting in a chair and has a very increased respiratory effort and respiratory rate. Their initial assessment, the doorway assessment, is that the patient does seem very focused on their breathing, but she does look up and acknowledge the crew. Her skin actually appears just fine. She does appear slightly diaphoretic, but nothing too alarming. They're not sure if it's just from her work of breathing or what have you. Every really sick patient I've ever had, like if I see them that they're sweaty, I want a really good explanation for that to get me to stop worrying. You can't really sweat on command. That's why it worries me so much, is it's an uncontrollable sign. But I guess she's only slightly diaphoretic, and given the how anxious she seems, it didn't strike young McDonald as mind-blowing and out there.
And the temperature in the arena, is it like cool, or is it one of those places where it's pretty warm?
The room that they're in seems a little bit warm, not like sweat about it warm, but the rest of the area of the arena where there's a concert and all that stuff, you have a lot of people packed in a closed place, so it's entirely believable that she could be simply sweaty from getting just really into the unicorn convention. So,
of course,
entirely viable. So, young McDonald does a great job at starting their initial assessment, says, hey, what seems to be going on today? And he noticed that she's only speaking in probably like 3-4 word sentences, but she is able to speak and kind of like keep her thoughts together and get out. And she goes, yeah, I just started getting short of breath. I thought it was an anxiety attack. I have a history of anxiety. And so I took some edibles and it hasn't helped. So he did clarify, he goes, when you say edibles, you mean like marijuana, right? And she says, yeah, I mean marijuana. And she says that normally helps her anxiety. It did not help her anxiety today. So he asked about how long it's been going on. She says, honestly, I've been having a little bit of trouble with it over like the past week. I do have a history of asthma as well. Of course, this is in like short sentences. And today it just got really worse, but I really wanted to come to the show, and I came to the show. I came to the unicorn convention. And she was out there unicorning and suddenly just really really got short of breath and had to come back in. So Spencer, at this point, what are some of the things that you would want to know or questions that you would want to ask?
Well, I mean, there's sort of a lot to explore here. Mm-hmm. So, I think assessment-wise, what I'd like to know is, what do lung sounds sound like? I want to see what, like mucous membranes, fingernail beds. I want to see if there's cyanosis there. I'd like to see what her vitals are, specifically a blood pressure, and saturation and pulse. If we can put an end tidal cannula on and get an end tidal reading for an accurate measurement, that'd be great. But I can tell, like, from just, the few word sentences, she does seem to be working to breathe. And then history wise, I want to know, have there been significant changes in meds? Have you been using your inhaler a lot?
Really good questions.
You know, did you, you know, in terms of the edibles, you know, it's like, is this the kind that you normally take, or is this a, you know, different kind? Because there are different strains of marijuana that have a myriad of effects. You know, it's like, well, I don't know, I tried this other one today, and it's like, okay, well, that's maybe not great.
Maybe it wasn't a
You know,
great
but
idea.
I, you know, the other thing I want to know is, you know, looking at, you know, things that could kill. Hey, any chest pain? You know, any pains anywhere?
Yeah.
And also, like, hey, are you a smoker? Do you take birth control? Have you had, you know, limb pain?
Talk about the birth control really quick. Why is that particularly important?
So birth control can cause an increase in clotting.
Yep.
And clotting then, of course, can create little emboli that go all over your body, and, you know, rest in your lungs or in your brain, or, you know, wherever they want.
You bring up some very good points there. What I really like about your question, Spence, is not only are you focusing on her current symptoms, you're also expanding it to include other stuff. It's casting that wide net. Unfortunately, you weren't on scene. Young McDonald was. And so as far as the assessment goes, young McDonald essentially accepts the EMT's assessment at face value. And the main reason for that is because the initial set of vitals really seem to support, at least as long as all you're doing is looking at a piece of paper with vitals on them, the initial assessment from the EMT. The EMT that gave the report said, hey, lung sounds are clear. She's just really worked up, and her vital signs are fine. That was essentially the report, and that she has a history of anxiety. Lung sounds are not rechecked by either young or old McDonald at this point, and the main reason is because the vital signs come back as this. Heart rate, 124. Blood pressure is 116/78. SaO2 is 97% on
Oh, is it
air.
SaO2 or SpO2?
You're right, SpO2. We did have a listener call us out on this. There is a difference between SaO2 and SpO2. So yeah. Right. So the SpO2 reading is 97% on room air. So they don't have any source of oxygen on her whatsoever. The respiratory rate wasn't checked. I don't have a number, but they said it was fast.
Okay.
So what do you think of those vital signs so far?
Well, so we have a patient who's sitting, who's worked up with a resting heart rate of 124. And so I'm curious now. I'd want to do, you know, I want to listen to lung sounds. And
but we won't get them for you.
I know. And I'd probably want to do a 12 lead.
Okay.
You know.
What do you think about the saturations?
97% on room air.
Yeah.
I mean, I guess they're not super scary. Like, that's not a number where I'm like, holy crap.
Sure. They are oxygenated, objectively.
Like but it sort of begs the question of, like, okay, why are they, you know, like, for a 19-year-old, you know, maybe with asthma, again, lung sounds will kind of help
sure,
clarify the picture. But let's say clear lung sounds, like the EMT said, then it sort of begs the question of, like, okay, like, why are they low? Like, why is a 19-year-old at 97%?
Sure.
And why are they breathing so fast?
And I think that's what it comes down to me is we've talked about this on the podcast a lot, and you'll always hear us say is you got to remember, vital signs need context. 97% as just a number in front of you is fine. This patient is objectively oxygenated. Okay, you can't get around that. All right, and that's okay. But what you got to look at is this patient is working really, really hard for 97%. Okay, and it could be you listen to lung sounds and things are clear, but whenever you see someone with an increased respiratory rate and they're really working hard, you really need to be listening to lung sounds and double checking. Because even if they were 100%, if you have someone who's working that hard to maintain 100%, there could be a reason, okay? It could be that they are constricted, and we need to make that easier on them. But, unfortunately, we don't really get lung sounds on scene. Now, you mentioned end-tidal capnography via like a nasal cannula, for example. I thought that would be great. I asked the question, and the answer came back is that normally they would have considered it. However, because the crew they're responding with is not ALS, even though the event is, the end-tidal capnography is usually kept with the monitor, the cardiac monitor at these events, and this crew does not have a cardiac monitor with them, so there is no end-tidal capnography available, which goes to your other point, Spence. You can't do a 12 lead because you don't have the cardiac monitor with you.
Yeah.
Just
Okay.
didn't bring it in.
The quick solution there, and I'm hoping this is where this goes, is they either say like, oh, hey, well, where's your medic with the monitor? If they're available, come down here. Or, all right, let's go to the ambulance.
Okay, so they do not call for the other medic, which, given the size of the arena, that it was probably just as fast to go back to their ambulance. But one of the things that I want to point out that I mentioned in the first place is that ambulance is actually a long jaunt. It's a rigmarole to get in and out of this place. So you have quite the space. And now we're going to compound it. So what young McDonald suddenly decides to do, young McDonald says, hey, we need to move this call along and just get this patient out of here and get going. Because at this point, and young McDonald openly admits, they're thinking, it's anxiety. Because the EMT said the lung sounds were clear, even though I didn't check them. The saturations are fine. In an isolated scenario, they're fine. The heart rate's 124, but, she was out there unicorning.
We're just talking about it. My heart rate's 124, so.
Right.
This had better be pretty freaking important.
One last question, and maybe you don't know. Did she readily agree to go to the hospital? Because to me, that would be another piece is like, if this person's like, yeah, please, then that also...
Yeah, I admit I didn't specifically ask the question, but there was no resistance was offered up whatsoever.
Okay.
So, and that's actually a great point. Patients who really want to go to the hospital, I should tell you, especially when they're at an event they want to stay at. I mean, this patient came to the event ignoring earlier symptoms from the other day so that she could unicorn the F out. And now...
now she's bicorning.
And now she's... What?
You haven't heard of a bicorn?
No. But before that, we are going to go ahead and talk about this episode's sponsor, Jump Medic. Jump Medic kits just have equipment that the others don't have. You've got a CBG kit, a blood pressure cuff, things that actually allow you to assess a patient that for some odd reason is missing in the competition. It sells for $279 and you can get 10% off of that using the EMS 2020 promo code. Also, you can check out the Jump Medic Elite or even design your own kit with the Build-A-Bag function. And whatever kit you choose, you can keep it stocked year-round with a $99 per year subscription, which comes down to just 27 cents a day. So check out jumpmedic.com, use the promo code EMS 2020, and be prepared for just about anything.
No, it's a unicorn with two things.
I mean, I figured.
But now she's bicorning out, piecing out.
Oh, she's piecing out.
And also bi-corning.
I don't.
Yeah, that works on so many levels. Yeah. I mean, two, really.
Yeah, two. It's a bi-level joke. Oh, God. All right. So, with that, they just
almost had to go to a trichord.
Nope.
All right.
Nope. We're not.
Nope.
Yeah, McDonald looks at the patient and says, hey, our ambulance is down in the garage. You think you can walk there or do you want to ride on the gurney? They have the gurney there. For me personally, I just put patients on the gurney because it's easier.
Right.
And she says, yeah, but I need to find my friends and let them know that I'm going first. She says in so many sentences. So they wait just a little bit longer. She's texting her friends. One of them's coming up and she wants to be able to give her friend her stuff and that kind of stuff. So they are waiting in the med room and waiting and waiting. And they notice the patient just keeps getting more and more anxious and kind of riled up and all that stuff. And they start telling her that, okay, breathe in through your nose, out through your mouth, kind of the anxiety coaching, that kind of thing.
Yeah.
Which, by the way, on its face is actually not a bad thing to do for a patient who needs anxiety coaching. But the other thing they notice is that the saturations are now down to about 95%. And they don't really bat an eye at it. They just kind of let that roll. So they don't check any additional vital signs. The patient's friend comes up, she hands off her stuff, and then she starts to say, hey, I'll walk, but she ends up just getting on the gurney because she's like, you know what, I feel really short of breath. I'm going to get on the gurney. So this is where things go south in a hurry. They start to push the patient back down to the ambulance, and when they get the patient into the ambulance and they load the patient, suddenly young McDonald has a thought, and it's the same thought Spencer had. Finally, this is where, because she has a history of asthma, finally, young McDonald says, hey, really quick, did you use your inhaler today? And she says, no, I didn't bring my inhaler.
Mm.
So she doesn't have it at the unicorn event. And she didn't use it earlier in the day. Now that her saturations continue to drop, her respiratory rate continues to go up. They put her back on all the monitors. They find her to be in a sinus tachycardia. They do end up putting her on an end-tidal nasal cannula, and it comes back at 31. Respiratory rate is in the high 30s to 40s at this point, which is plausible for a 19-year-old. And they notice that the oxygen saturations are down to 92%.
Spencer, what do you think now?
I think that now is the time to listen to lung sounds.
Now is the time to listen to lung sounds. Yes. Young McDonald admits that they initially said, hey, these lung sounds still sound clear. Old McDonald, who's been around the block a little more, who's looking at the same patient, says, let me listen. The lung sounds are not clear. They are not audible.
Oh.
In other words, Old McDonald isn't able to hear any lung sounds. Why is that bad, Spencer?
Well, because that means that air is not moving through the lungs.
Right.
Well, I mean, not loud enough to hear anyway.
Not loud enough to hear. So that's kind of one of the things to remember about bronchoconstriction, right? Is that if you start out with wide open bronchioles and there's no air impedance whatsoever, you hear kind of a nice whoosh. And sometimes the movement of clothing or the movement of skin underneath your stethoscope when someone inhales can sound like a nice whoosh. Then what will happen is as those things constrict, they'll start to get whistly.
Sorry, Rod, what was that?
Whistly.
You're saying it weird.
Saying what weird?
All of it.
Where do you get off?
I just don't get why you're saying it that way.
Why I'm saying what way?
Because that constriction causes a whistling of the air, and that's the wheezes that you get that's commonly associated with asthma. The problem, though, is that once the asthma, the bronchoconstriction gets so bad, air no longer moves through them. And now you get quiet lung sounds. So lung sounds in patients with bronchoconstriction. So, you have asthma patients. Another patient that would have bronchoconstriction would be like an anaphylaxis patient. There are some more advanced diseases that are more commonly in the elderly and are associated with like COPD that can also cause some constriction in terms of like inflammation. So what you have is you have normal lung sounds that don't make a lot of noise. Then you have noisy lung sounds. And then when it's really bad, that's a problem. So in this case, Old McDonald is pretty concerned and wants to get started on this. Spence, what would you do?
Well, let's start with some nebulizers. A duoneb. I'd have that nebulized in if the patient can't hold up the mass or the acorn on her own. Then you take out the non-rebreather bag for a non-rebreather mask, and you can plug that in. Yep, and throw that on their face. That way you don't have to hold it. You still have all your hands, and you can do other things like get an IV, give steroids, and and start undoing the
undoing what's done. All right. So what ultimately ends up happening is they decide that they're going to go ahead and transport licensed sirens to that nearest hospital because they do start the duoneb, as Spencer suggests. They didn't use your mask trick, but she was able to hold it, so that was fine. And she appears to get very tired. And the duoneb ultimately didn't really help a whole lot. It kind of brought her saturations from like 92 up to about like 94%. So they decided to go code 3 licensed sirens to the hospital. After the first duoneb is done, they put her on high flow oxygen. They go to start another duoneb, but so she does get it started prior to going into the hospital, but not long enough to really see the effects. Her saturations never really go above 92 or 93%. They did get IV access, by the way. We'll say that did occur on the way out. They arrive at the hospital. They turn patient care over, and ultimately the patient ends up getting a dose of epinephrine through the IV. So the patient never had to go to the ICU. They were discharged later that day. But let's kind of talk about where things went wrong, and let's kind of talk about specifically the treatments for bronchoconstriction. So before we get to the treatments for bronchoconstriction, I will put a pin in what you said, Spencer. You would give the duoneb. Okay, we'll talk about the 2 medications that are present in that. But I also want to talk a little bit about the kit issue. So I think from the get-go, there were some system issues that kind of set this call up to fail a little bit. So I think one of the early on issues that I recognized is that we really wanted this to be anxiety, right, when we walked in, because anxiety is so easy to treat. And so there's a lot of incentive for this to just be an anxiety call, right? Because it's easier. And the other thing too is I think innately we don't want people to be hurt or sick. You know, anxiety attacks, while I do believe we should take them seriously because it is a major event for the patient, typically it's not a life-threatening event. There are other factors that keep drawing us to that conclusion that it's just anxiety, or rather make the conclusion of anxiety more appealing. One, if it's worse than anxiety, we didn't bring in the kits to actually treat it.
Yeah.
And so that was kind of something I wanted to bring up. And Spencer, like, what's your opinion of the system they have in place? Like, what are the holes that you saw that probably led to not having the equipment for this patient? Because they didn't have the equipment for this patient.
Yeah. Well, I mean, I guess this sort of just exemplifies even if you have a, you know, like if you have a standby where you're used to, you know, the crew at the standby who's a different company having very similar kits available, that isn't a guarantee. And so it's still worth bringing the equipment that you might need for the call that you've been dispatched to. Yeah. It's again, I think it's totally okay to consider that anxiety attack, or like, oh no, you know, like the marijuana induced anxiety attack, given the, you know, the dispatch, like that can still be at the top of the list.
Yeah.
But there are other things that, again, like our job is not to find the one thing, it's to identify multiple things that could be wrong. So going in there with the equipment to help you identify those other things that it could be is crucial. It makes sense. And I could see myself falling into the same trap of like, oh, I thought you guys had the stuff that we would need to run this call. But when you're, you know, when the equipment you need is, especially when it's like really far away to correct that mistake. It's one thing if it's like, hey, they're on the other side of the store where our ambulance is parked. They usually have the equipment. And if I'm wrong, I'm running out to grab more equipment, you know, the monitor or whatever. But when it's, you know, you have to tickle a troll's toe to get through, you know, to where you need to be, that makes this even more of a trap, I guess.
It does. I understand that lugging a lot of equipment through a large complex is it's a pain, but generally speaking, you can fit it on your gurney.
You know,
I was going to say you have a cart with wheels.
Yeah, you could try and design complex policies around it, being like, okay, like maybe we communicate more and see if they're with the ALS crew or the BLS crew. If they're with the BLS crew, then we know to bring that. But my problem with that is that's so many points of failure. You know what I mean? Like they could communicate it incorrectly. The ALS crew could get called to another call, you know, where that's more critical. There's so many things that could happen. So in this system, I would say, even though there's good kit parity, this is one of those where the best policy is to bring in your own kits, all of them. And the reason for that is that by the time you realize a mistake has been made, you're a long way away from your kits. And any other policy would just be really hoping you're guessing correctly. And so take the guesswork out and just bring them in every time. Worst case scenario, you have to be like, hey man, hey, standby EMT, would you mind helping us take our kits out? Because we have all these kits. That's not terrible, you know, because the patient's now on your cart. That's not a bad outcome. How about that? That is a better outcome than not having your kits on a patient that is needed. So yeah, I think because they didn't have their kits present and because they already kind of wanted this to be anxiety, I think there were just a lot of factors that made anxiety so much more appealing than something severe.
Yeah.
So
I think the other thing too here is there was a lot of you know, of trust from the oncoming crew to the EMT, or to, you know, like they're and one of our old training managers, wonderful guy, you know, they said like, hey, trust but verify. You know, like there's nothing wrong with listening to lung sounds, even if they'd say, hey, I listened to lung sounds and they're clear, you can still go, okay, awesome.
Yeah.
And then, plug in your thing and listen.
Yeah. And if you don't want to offend them, just say, hey, I'm going to make sure there isn't a change. I'm just going to make sure it hasn't changed.
Exactly.
I'm always weird about the word trust because everyone is capable of making a mistake. Everybody. Your best, most solid paramedic that you have ever met in your entire life.
Never made a mistake.
Has made.
I thought I did once, but I was mistaken.
A bullshit?
A bullshit. A bullshit. A bullshit.
So, right, but everyone has made a mistake. And so when I say, I don't want to say trust no one, but what I'm saying is you can only trust people's intent. That's what you can trust. I trust that someone intended to do well. I trust that when he listened to lung sounds, he intended to get them accurately. You can trust that intent. But because everyone can make a mistake, everybody, when the patient's life depends on it, verify. And it's worth it, because the downside to verifying is you upset somebody and hurt their ego.
Yeah.
Those of us that have been doing this long enough and have made the mistakes, if someone's like, hey man, I'm going to double check, I'm more of like a thank you.
Yeah.
Thank
Yeah.
you.
And to your point, old Mickey D.
Yeah.
He checked those lung sounds.
Exactly.
And then he plowed ahead with the call, as it should have been.
Yeah. Yeah, he did. I will point out it was actually young Mickey D that was in the back and transported to the patient. Old Mickey D.
I know, but
Yeah.
Young Mickey D went, "Oh, the sound's clear," and
Yeah.
old Mickey D said, "They don't sound actually."
Yeah, they sound zero. They have zero sound. So yeah, that was not great. So let's kind of move on to the medication and the treatments, and kind of like let's talk about why they didn't get a lot of headway with the Duoneb, why IV epinephrine ended up working well for this patient. So let's talk about what is in a Duoneb, Spence.
It's 2.5 milligrams of albuterol and 0.5 milligrams of ipratropium.
So yeah, so you have these two medications, and when in the case of albuterol, what albuterol does is albuterol causes bronchodilation. Okay, it's what we call a beta 2 agonist, and it makes those airways that are so tight a little bit wider. Ipratropium, which is the other medication in there, will help stop mucus production within the lungs. And so it will help dry up the lungs a little bit. So if you have an obstructive process in terms of like mucus, which is especially common in people with like COPD, then this can help kind of clear the way. If they don't have mucus in there, then fine. It doesn't, it's just there. So it's not a problem. So a lot of us, I don't know about you, man, but I typically just start with a Duoneb now on pretty much any patient with constriction. I know there are some protocols out there where they want you to give just albuterol. Always follow your local protocols. But generally speaking, a lot of agencies are just saying, hey, start with the Duoneb, which is just both those drugs combined.
Yep.
Anyway, so that is that. But the problem with a medication like a Duoneb with the albuterol and the ipratropium is that it requires that the patient actually has to be able to inhale it. And so as this bronchoconstriction continues, that act becomes very, very difficult. And so they get very, very little of the medication inhaled. And so you're not seeing a ton of progress. In fact, I would wager, and this is just me spitballing, there's no way that I ever possibly know this, but I would wager that the slight bump in saturations they got was probably more from the fact that they now had the patient on oxygen, which she was not on oxygen prior to this, than the actual medication being able to do its work. Because by the time you have no lung sounds, you just don't have medication going to where it needs to go.
Yeah, that makes sense.
Yeah. So let's talk about getting epinephrine at the hospital a little bit. So epinephrine is a sympathomimetic, and whenever you have a sympathomimetic, it's the fight or flight response. And a couple things are going to happen. Your heart rate, going to go up. Your vasculature, going to get smaller. Because what your body wants to do when it has to either fight something or run away from it is it wants to get blood to the places that it needs to be, like the brain.
Yeah. To be specific, though, it clamps down on the little, the vaso, like the vein system.
Right.
But it dilates the arteries
Yeah.
so that blood can go faster to those places and return.
Yeah. Like to your muscles and things you suddenly need. Yeah, it doesn't clamps down your aorta to like that big, man. It's really weird. Then your heart tries to push out and it just pops. But anyway, that's not true. That's just me being funny. But the other thing that it's going to do is because we want this blood to go to these muscles that we now need, we want that because we want to be able to carry oxygen to the muscle for fuel, right? Well, the other way you're going to be getting a lot of oxygen to the bloodstream is by dilating the bronchioles. And it does that really, really well. And the best part about epinephrine is it's injected, not inhaled. So their respiratory status doesn't play the same role as it would in trying to inhale a medication like albuterol. And that's the great thing about giving epinephrine, is even if someone is really, really clamped down, epinephrine still has a chance to go in there and be effective. So really quick, we're going to wrap up this episode. That's pretty much the main treatments. But really quick, Spencer, what are the big changes that you think could have occurred on the scene? Because one of the things I do want to say about epinephrine is in a 19-year-old patient, I'm not surprised that the 19-year-old got discharged later that day. They're probably still there for a while. But if you have an older patient, they may not get discharged because they've received epinephrine, because epinephrine takes its toll, right? I mean, it's not an inert drug. It's going to increase cardiac demand. And in an older patient, that can really make a lot of physicians nervous and they're not so ready to discharge. So, Spence, casting age aside, if you had this patient, what are some changes that you would have made?
I mean, honestly, it's when you go in there, you have to do your own assessment and, and trust but verify.
Yeah.
And I think it's totally okay to have, like your first thought pop to your head, whether it's like, oh man, this person's really sick, or, oh, this is just anxiety.
Right.
They took the wrong edible. Like you can think those things, but again, like you should cast a wide net, think of other things that it could be, and just play the game. Like, how is this patient trying to fuck me? Like, how are they trying to ruin my career?
How are they trying to take my paramedic license?
Exactly. Like, because then you will be suspicious enough to look for the things that, you'll notice, oh, the sats are dropping. Because I think the thing that would have avoided this is they recognize that, hey, this person is having a very severe asthma attack now. They have a history. The history of like, oh, it's been getting worse for a week. That doesn't line up with anxiety. Like,
it doesn't. You're 100% correct.
So, there's all those sort of little things that are peppered in there that if they'd kind of, if they'd listened to, they could have started their treatments early and who knows, maybe like they could have gotten a refusal right there and then gone off to Mickey D's. Wait, hold on. They didn't want to go to Mickey D's. They were Mickey D's.
They were. Right. But no, I think that's exactly the point, because when it comes to those inhaled medications, there is a window in that process. And I think had they trusted the patient a bit more from the get-go and actually had the equipment with them to be able to deliver this treatment, you could have had someone that may have been a non-emergent drive to the hospital after an albuterol inhaler, or maybe even a refusal. I don't, personally, I'm not huge on refusals for like breathing difficulty patients, just because my big issue with her is that she's been having breathing problems for a week now. And so my worry is that I may give her some temporary relief from it, but then what's going to happen when I'm gone?
She's going to bother that. She's going to get to go back to the unicorn convention.
Let's get the unicorn out.
Right. Yeah, exactly. And then 2, that's going to be another shift's problem.
That's good. You know what? Never mind. Spencer Oliver for the win. That point stands.
Judgment.
So yeah, this was a great call. Lots of system lessons there. Try and bring in your equipment, and trust your patients a bit more. I think the other thing that I like about this call is, remember, vital signs need context. 97% is fine. She is getting oxygenated, but that respiratory work that's being done, if we can make it easy to get 97%, then let's do that. Because if anything, the patient, feeling short of breath is one of the worst feelings in the world, and this patient's experiencing it. And one way you can take that away is just by making it easier to take a breath. So with that, everybody, thanks again for listening to, or watching rather, another episode of Push Dose. Also, be sure to check out our podcast, EMS 2020. It's available wherever you get podcasts. If you liked the video, go ahead and drop a like. Also, subscribe and hit the bell icon to make sure you don't miss any more content on the Rapid Sequence Information YouTube channel. Thank you, everybody, and bye-bye.
Bye, corn.